So what I'll specifically focus on is this idea of identifying EPAs for our undergraduate medical education program, applying the idea of entrustment to assessment, and then additional curricular considerations that we would want to make in developing a curriculum. So I always say, let's start with the end in mind, okay? And what I mean by this is, if we want to think about outcomes, so what should our EPAs be? We want to start at the end and think about what are the outcomes that we expect of our medical school graduates, right? What should they be able to do with minimal or no supervision? And I should say that this is, different here in Mexico and in some Latin American countries, where students, after receiving their MDs, will go out and practice unsupervised. And this is different from much of the United States, Canada, and Europe, okay? And so as we learned yesterday, entrustable professional activities of the graduate are important, concrete clinical activities that we want to be able to entrust to our students or graduates to do, and that if we have a whole portfolio of EPAs, that actually then represents sort of full competence or represents that profession, okay? So the first part is, how do we decide what our EPAs should be, and how do we make sure that they're the right size, okay? So these are the ones that were developed in the United States, and many people in different countries have been borrowing them, adopting them. The Canadians have developed their own, which are very similar, and the Swiss also came up with EPAs that were very similar. But I would caution those of you from countries where your students have to be practicing, because when you look at this, this is actually very basic, right? So gather a history, perform a physical exam. It doesn't say actually take care of a patient. This is just a component of that. And for the United States, for Canada, for much of Europe, this makes sense because our medical students are not allowed to practice. They must do a residency. They must go on to postgraduate training. So the expectation is that they just need to be able to do this to enter postgraduate training, and then they'll learn how to take care of the larger EPAs of how to take care of a patient in postgraduate training. But that's not the case here, okay? But even within the United States and other European schools, people have looked at this and said, this is still too basic, even for our graduates who will go on to postgraduate training. So I'll give you an example. These are EPAs that were developed at Utrecht, at Professor Tenkati's institution. And you'll notice that they're more synthetic, right? So if you look at the first one, the clinical consultation, that actually includes the history, the physical exam, differential diagnosis, diagnostic testing, and coming up with a management plan. That pretty much incorporates about 5 of the US EPAs, right? So that's a higher level expectation, is that you can integrate those things to do an initial clinical consultation, right? Now I'm going to show you some EPAs from graduate medical education. And so when you look at these, they're definitely practice level EPAs, right? Now we're looking at managed care of a patient or managed care of patients with chronic disease. That comes from internal medicine in the United States. Care for a well newborn in pediatrics, that comes from pediatrics in the United States. And then care of uncomplicated pregnancy, which is one of the EPAs that was first published for GME from the Netherlands, okay? And yesterday, Dr. Hamui showed us some of the APROCs that were developed, and if we look at them, they come closer to practice level EPAs. So if you look at the ones for family medicine, rotation, establish control of the patient with a metabolic syndrome, or carry out control of healthy child under 5 years of age. And for the obstetrics and gynecology rotation, we're looking at provide prenatal care to a pregnant patient, and assess and assist in the care of the patient in labor. And that makes much more sense for graduates from Mexico, because they will be asked to do these things. Now, what I learned yesterday afternoon was that we even have higher level EPAs than this. So we have graduating student level EPAs that this are a part of, and I'll talk about that a little bit more. So once we have our EPAs that are appropriate to our situation, what our graduates will be expected to do, then what's important is that everything that I've showed you so far is just the title, okay? What's important is that we need to elaborate out metabolic syndrome, is it of all ages or certain ages? Is it of a simple, a patient with a non-complicated metabolic syndrome? So really, what are the parameters around that we're truly expecting of our graduate? And for those of you that are using a competency system in place already, so in the United States we have the ACGME competencies, you can map them to the relevant competencies. I think more important is looking at number 4, which is thinking about what are the knowledge, skills, and attitudes that your students need to have in order to achieve this EPA, okay? And what I often ask people to do is then tell me where in the curriculum they teach it, right? So when you fill this chart in, you're also saying, okay, in the first year we teach this, in the third year they get to rotate and practice this, and often when people are forced to write down where in the curriculum they teach the things that a student will need to accomplish the EPA, they discover holes and they discover gaps. And we realize that we're expecting things of our graduates where we may not explicitly be teaching them, and that's something then for us to think about as we continue to tweak and address our curriculum, okay? Now, one of the things, so that's what I wanted to talk about. The other thing is we start to think about, so we know where we want to be at the very end, but what are our benchmarks, right? So at what level of entrustment, how much should our students be able to do at each step of the way? Okay, so now I'm going to talk about that a little bit, because when we look at practice level EPAs, so these are the ones, manage care of a patient with a chronic disease or care of a newborn, care of an uncomplicated pregnancy, we might be able to visualize a graduate doing this. But what does this mean for a third-year medical student, right? This is very overwhelming. How are they going to manage or care for a well newborn? I'm a pediatrician. So what pieces of that can they do? So what we find is that for practice level EPAs, what we often want to do is we want to break that down into pieces that are easier for us to assess and easier for the students to do. And I'll give you some examples of that. So how do we take our graduation EPAs and break that down? And people tend to take 3 different approaches. One is to divide it into components. So for instance, the clinical consultation, we might break it up into history and physical and differential diagnosis. We might adjust or separate the content, and I'll give you examples of that, or we might adjust or sequence complexity, and I'll give you examples of all 3. So just to show you an example of how to do this and what nesting means. So this is an example of what we have in the United States. So we acknowledge that any school may have their own EPAs that they have defined for their graduates, but in the purple are the AAMC core EPAs. So we're saying that regardless of your school, regardless what other EPAs you have, these are the core ones that every student must achieve in order to enter residency training. So these ones then nest up into the EPAs from residency training, which might nest up into, in the United States, we have fellowship training for the super subspecialist, okay? So we take that and say, so I'm going to show you how the AAMC core EPAs might nest up into a practice level EPA. So let's take practice level EPA of managed care of a patient with chronic illness. So if you think about breaking that out, we have in the AAMC, you have gather a history and perform a physical exam, recommend and interpret common diagnostic and screening tests, document a clinical record, clinical encounter and a patient record. So all of those things provide the foundations for being able to manage care of a patient with chronic illness. And we can further break that down. So now I take, gather a history and perform a physical exam. Now I can nest it using components like I talked about. So I can break that out so that a more junior student would have to just achieve an EPA and gather a history, or achieve one in physical exam before they have to integrate that. I might nest it by separating the content. So for instance, gather a history and perform a physical exam, I might say that as the student rotates through the different departments, they're responsible for achieving an EPA for patients of that department. So being able to do a neurologic history and physical, being able to do a gynecologic history and physical, pediatric or psychiatric. And by going through all of those, then they're able to do a history and physical across a context, multiple contexts and multiple types of patients. Another way to nest, which we did at the University of California, San Francisco, where I used to work, was to say we can adjust the complexity. So I used to direct a doctoring course for first and second year medical students where they're just beginning to learn to talk to patients. And so what we said was we established an EPA for early medical students saying that they need to gather a history and perform a physical on a medically stable patient with a common chief complaint, right? And in our limitations, we also said that this had to be an adult. They have to be cooperative, not angry, right? They have to be cognitively intact, right? So you keep it very simple for early medical student, and then you can increase complexity as they go, so by the time that they graduate, they're able to do the history and physical across all patients. Okay? And I'm going to show you an example of how this has been done at Utrecht. So Professor Tenkati published the curriculum in Utrecht. It's a 6-year curriculum, which is nice to look at because it much more parallels to what we have in the Latin American countries. So year 3 at the bottom, so the Utrecht students also begin clinical work in year 3, and then we have year 4, 5, and 6. And they also have a sort of a modular curriculum, and you can see here green, red module, blue module, yellow module, purple module, okay? And what they've done is, this is where I've shown you before, is they've taken the first EPA, the clinical consultation, and then broke it down so that the students are achieving parts of it in different modules. So in certain modules, they're learning they're achieving the EPA for a neurologic consultation, and in a different module, they might do one for a perioperative consultation. Okay? And what that means is, again, if we lay out the curriculum, so across the top are the different modules, the green module, red module, blue, yellow, and purple, and then each row is the different EPAs. You can see where each star is where the students are being assessed at a summative level in terms of did they achieve that EPA and can move on to the next module. Okay? And so you can see where the students are being assessed on these different subcomponents of an overall EPA. And another graphic then is, this is another way to think about it, right? So the graduation EPA are the big circles at the top, but each of those big circles can be broken down so that, even down in year 3, students can be achieving a small EPA that will eventually nest up into this larger EPA. And I like to show that you're wondering, she's crazy, why is she showing us a cake? Okay. And this is to show that we naturally already think this way. So I show you a cake because I have a niece who's 11 years old and she loves to bake. Okay. And she's always been, a little bit of a pest in the kitchen, right? So from when she was very young and you're baking, she wants to participate. And any of you that have worked with small children know that. They're never happy to just watch, right? They want to do something. They want to contribute. And we find ways to allow them to participate, right? So when my niece was young, I could have her under very direct supervision measure out dry ingredients. And then over time, I could entrust her to measure the dry ingredients, but that's just a small thing, right? And then eventually I can entrust her to bake the cake, right? And now she's at a level where I can actually entrust her with distant supervision to bake a multi-layer cake that's fully decorated for someone's birthday. All right? So if we think back to what you do for people that you work with, we do this all the time. We naturally break things down so that the people can take responsibility for a small piece, and then those pieces eventually integrate up into a larger responsibility. And that's all we're doing with our EPAs. Okay. So now that we have our EPAs and we can use smaller EPAs for benchmarking, let's talk about this idea of applying supervision or entrustment to assessment. Okay. I'm just going to grab. So I'd like to use this picture. This is the Golden Gate Bridge in San Francisco. Often gets very foggy, okay? So let's say that you have a neighbor who just received their driver's license and they want to drive your brand new car, okay? How do you decide that you trust them enough to hand over the keys to your brand new car? And does it make a difference if your child is sitting in the back seat? Okay? And so the question is, do we want to know that they passed the exam, right? Do I want to know that they can turn left and turn right and make a U-turn? Or do I want someone to tell me that, you know, I've been riding in the seat with Jose for a very long time, and I can tell you that he can be trusted to drive safely in the fog. Okay? And that's really what we're talking about, is shifting our frame of thinking in assessment, the thinking about entrustment. Okay? So the beauty of this is, in some ways, this very much already aligns with what our faculty supervisors already do. So when I'm in clinic and I'm trying to decide which patient, which resident or student to send in to see which patient and whether I need to be in the room or not, I'm making that decision about how much do I entrust them to do with how much supervision, right? And what we find is faculty find it much easier to tell us how much supervision they think a student needs than to say, well, this is an excellent student or a poor student, or on a scale of 1 to 7, that's a 6 or a 4. The other thing is that it really places patient safety front and center, right? It's not so much just only about the student anymore. So often when we give grades or when we give a rating of 1 to 7, it's about the student, right? Am I a good student? Am I a bad student? But when we talk about entrustment, it's really about the patient. It's what can you safely do under what level of supervision? And again, clinicians think this way, right? When they're making choices in the clinic. The other important thing about this is when we base everything on supervision, then when a student has shown me that they can be trusted, it means that I can back off supervision. So the result of these decisions is that the student gets more and more responsibility and more autonomy, which prepares them to then practice unsupervised. Okay. One thing I also want to bring up is that often when we've done ratings of students, we've only rated them based on ability, right? We privilege ability over everything else. But when we begin to talk about trust, so when I talked about trusting your neighbor to drive in the fog with their child in the back seat, it's not just whether they're not a good driver, it's whether they're going to be careful. Are they the type of person who takes risks? Are they going to run yellow lights, right? So we start to think about this idea of trustworthiness, and it's based not just on their ability or the level of knowledge, skills, and attitude, it's how conscientious they are, right? How consistent they are, whether they're truthful. When I ask them if they've checked the labs, they're going to tell me they did or they did not, and that they recognize their own limits and they recognize when they need help, right? That this is something that they don't know how to do, and they really need to get someone with higher expertise. And so what Dr. Tenkate has done is sort of simplify that and has us think about ability, and then reliability, integrity, and humility. Okay. So just to give you an example, and this is actually based off of a real-life experience I had working in clinic, is let's say I work with 2 students, David and Amy, right? David has, he's an average student, exactly where we expect someone to be. But what's nice about David is he knows what he doesn't know. And he will come and tell me when he doesn't know something, and he asks questions all the time, right? Amy is really impressive, okay? She has amazing knowledge and skills. Everyone says this is the best medical student we've ever had, except that Amy never asks for help, okay? And I find when I double check, sometimes she doesn't report key findings. And what I find over time is I actually give David more and more responsibility because I can trust he'll come tell me if he doesn't know something. And I end up supervising Amy more and more because I don't trust her. I am not sure that she's safe for the patient. So that's a difference when we begin to rate using entrustment instead of just focusing on ability. Okay. So then these are the levels of supervision, and Professor Tenkate showed us this yesterday. This was a scale that was originally published. And the idea was that when someone finished residency training or graduate medical education training, they would move from reactive supervision to practicing under limited or unsupervised. And one thing we did was to say, we expanded it for undergraduate medical education so that the steps aren't so big, right? So if we think about first under full supervision under 2, we might do something together. So imagine putting an IV together, and then maybe I'm in the room, but I'm going to let you do it. But I have gloves on and I can step in whenever you need me to. And then reactive supervision is I'm outside, I'm going to let you do the history and physical, but I'm going to double check everything, or maybe only double check certain things, or that I'm actually not on the same floor and we can talk about it by phone. Okay? And I think level 4, we've played with, should it be unsupervised practice, or in most cases it's probably limited supervision, right? Maybe there is someone that you can call and talk to, someone who reviews your cases once every few days or once a week or something like that. And I should mention that there are other types of entrustment and supervision scales out there. This is one that was published for surgery, where the surgeon could report whether or not they had to show and tell the learner everything, or they had to actively tell the learner what to do during the operation, or they could just let the learner do it and then step in when they felt the learner needed guidance, or they didn't need to provide any help at all. And what we found from people who are implementing these supervision and entrustment scales is that you need to change the wording so it makes sense to your faculty in whatever context they are, that's exactly how they think. Here's one from anesthesia from New Zealand in Australia. And so in anesthesia, their decision is, can I leave the operating room and how long can I leave for? So you see, leave for a coffee break, or maybe I can leave for lunch, eat the whole lunch and then come back, right? And what they found is that when they studied using this supervision scale, or a rating of 1 to 9, is it had better inter-rater reliability. So the faculty were more able to agree with each other on how much supervision a resident needed than just rating them on, because your 7 might be my 6, and then might be Dr. Samui Hutton's 9, right? So, but we get closer when we think about what's safe for the patient. All right. And I do want to bring up that when we start to talk about using entrustment for assessment, there's 2 different types of assessment. So there's ad hoc, which is I am with the student in the clinic, and I'm making decisions, day to day, based on every case. How much supervision do I think you need? How much supervision am I going to give for these patients? And then there's the summative decision that essentially the school makes, right? That this student has successfully completed this module, can move to the next module, can actually formally be given more responsibility, okay? And Dr. Tenkate showed this form, and this has been used by some places to say that if 3 different supervisors say that you're ready for less supervision, then you can have less supervision, okay? And I will tell you that in the United States, this makes us very nervous. And so in the United States, what we prefer to do is we prefer to have competency committees. So what we do is to say, we feed a lot of information to the committee, and the committee makes a decision on whether the student can be granted more responsibility. And the committee can use can use information from the faculty who are working with the students in the clinics, but as well as information from simulations, from written exams, from portfolio, and this is just an example of all the different types of information you can give to a competency committee to make the decision. The other very important thing I want to bring up is that as you look at the way people implement entrustment supervision scales, there's 2 different ways to use it. One is to look backwards, and one is to look forwards. So the ones that look backwards basically ask, how much supervision did you have to provide? The ones that look forward ask, how much supervision do you think the student needs next time for the next case? Vanderbilt University implemented EPAs, and they actually couldn't decide which scale to use, retrospective or prospective, so they used both, and they were able to compare them. And what they found was that faculty found the retrospective scales much easier to use. Makes sense. It's a lot easier for us to say what we did, right? But what they found, surprisingly, is that the ratings don't really relate. And so they're trying to figure out why. And one of the thoughts may be that when we do a retrospective scale, it's much easier to fall back on thinking about ability, right? How much ability did this person have? But when we are forced to think prospectively, now we have to take into account, is this, student what we would call a cowboy, right? They're out there doing things on their own. Is this someone who will recognize that they will need help if the next case is more complex or different, right? And so another thing I want to say about future performance is, so here are numerical ratings of two different students, okay? The blue student and the red student. And I would say that usually the way we approach assessment is we ask, what is the average competence of this learner, of this student? And if you ask that question, the blue and the red student actually have the same average numerically. But if I tell you that the zero, okay, on the y-axis is what is safe for patients, qualitatively, student 1 is different from student 2. They may have the same average, but if you look, our blue student dips below safe levels. Our red student never goes below safe levels. So now when I ask, how big is the risk of this student performing seriously below standard for a future case, the answer is different, right? And so that's the power of using a prospective scale. That's the power of thinking about entrustment and looking forwards instead of just looking backwards. And I think that as we think about EPAs, implementing our curriculum, and as we think about assessments, is we don't want to fall back on the ways that we've always done assessment, right? We want to really tap into this power and change how we think. Especially, we're sending our 6th year students out into health service, and really, what's the risk that they're going to be dangerous for a patient? Okay. So a couple of other things that we'll have to think about in our curriculum to allow sort of EPAs to work the way we'd like them to work. One is that we've been talking about basically core EPAs, what every student needs to have to graduate with the MD. But there are other things that you may want to think about. So for countries where most of their students go on to residency training, can they begin some of the work already while they're a student? And there could be elective EPAs. So yesterday I heard about students who during their service year or later on in practice may opt to work in research or education or in health maintenance. And so are there certain EPAs for that students could then say, this is their selective EPA, and they can be certified that they in fact have the skill. Right? With EPAs, we're talking about entrusting someone to perform a professional activity, which means that people need a lot of practice, right? So we have to build practice into the curriculum. And yes, definitely with simulation, with standardized patients until we feel like they're safe to be practicing on patients, but it can't just be simulation, right? Because we all know that the real world is very different from the controlled setting of an OSCE or a simulator. So students need to be able to practice in the real world as well, so that they can, so we know that they're working towards achieving that EPA. And that these opportunities for practice must be observed. Right? This is a huge problem for us in the United States. Oftentimes we're not observing the student. The student comes out and presents to us, and we make all sorts of inferences about what actually happened in the room versus being in the room and seeing whether they did the physical exam correctly, for instance. Okay? So in order for the faculty member to really tell you whether they can entrust someone, they have to have opportunities to observe the student practicing those EPAs. The other thing is that we want to build a curriculum that promotes longitudinal relationships. So I am a pediatrician that works in our urgent care center. And the way it was staffed was that we had a different faculty member every half day. So in a week, the poor medical student has worked with 10 different faculty members, right? So I could explain something to the student on Monday afternoon, but then I don't know whether the student's practiced and improved and looks different by Friday afternoon, right? So how do we create curriculum where we have longitudinal relationships? The other thing is, now that I'm talking about entrustment, and I say we want to know that our students are honest. I want students to be able to tell me that, they overslept, so they actually didn't check the labs, don't know what the labs are, right? Or admit that they've made a mistake. But that means the student has to know me and has to trust me, right? If I want students to be honest, then I have to be part of a system that does not punish the student for being honest, that can say to the student, thank you for being honest. It's more important that I know you did not check the labs than for you to give me false information, right? And all of that is promoted with a longitudinal relationship when we've worked together for a year. then you know you can trust me. You know that I care about your development, and that all of the feedback, everything that we do is to help you achieve these EPAs and be a safe physician. Okay. The question that often comes up is everything we talk about with the EPAs is really about workplace-based performance and workplace-based learning. So the question that often comes up is, what about classroom learning? And I think what's we're seeing in the United States is as many schools are implementing EPAs in their curriculum as they're not actually involving their preclinical faculty members. And I think that that's a big mistake, right? So one of the things is that the classroom learning supports the workplace activities. So if we can show the students and show the faculty the reasons why they're learning things in their preclinical years and how that maps to the EPAs that they're going to be expected to achieve, I think that helps provide clarity for everybody. The other thing is that we've been talking about the need to promote integrity, reliability, and humility, as well as ability. We want our preclinical faculty to be with us on that, right? So if you think about in our preclinical years in classroom learning, do we only grade the students or rate the students on ability, right? Are there opportunities to rate them on, being admit when they don't know something, right? Being reliable and consistent, and someone that their teammates can depend on to look up information if they're working on a team-based learning exercise or a problem-based learning exercise. And the other thing is that, I think I will show you this next slide, is often most medical schools are set up where we have learning in the classroom, in the science learning, and then we have a big change where then we step into learning in the workplace. And ideally, we want more of a Z curriculum, right? So we do a blending of the two, and the students gain more and more autonomy. And so with this model, then, we do need to be thinking about workplace learning as early as even day one of medical school, okay? And now, some people will argue, first and second year medical students, we can't have them in a clinical setting. They don't know anything, they don't know how to do anything, okay? That's often what we thought as well. But, in the United States, and we have our students who are in the classroom, that's not why they came to medical school, right? They want to be working with patients. Many of the medical schools in the United States have student-run clinics that provide care to populations that do not have insurance or are marginalized. And these medical students say that when they're in these student-run clinics, they actually get to do a lot, right? Because the systems are set up. And again, think about the EPAs. They're able to pull off a very small piece that the students can do with appropriate supervision. And these are just pictures from various student-run clinics in the United States. The one, the big one, where the students are actually wrapping someone's leg, that actually comes from San Diego, where San Diego medical students collaborate with medical students from Mexico in providing care to patients along the border. Right? And these are early medical students who have not started their clinical training yet. So as we think about EPAs and thinking about pulling them down and incorporating our preclinical faculties, also think about how early can we begin our clinical skills training, and what are ways that we can involve students where they still can contribute to the clinic. Okay. So what we've talked about is implementing EPAs in UME, and what I really wanted to share and to push forward is this idea that this really is a paradigm shift, right? It's not a simple curricular change. We're really thinking about our outcomes. Where do we need to get to? What is it that our graduates need to do? And then we have to build a curriculum that supports that. And in thinking about these nested EPAs and smaller EPAs, and each EPA is an entrustable professional activity. So the beauty of that is it allows us to see our students as contributors to the patient care and to the health system, right? Rather than as burdens. So in the United States, we often think of early medical students as a burden to the health system. They slow down the clinic, they slow down the faculty. But this way we can see that, no, they can contribute. This is what they contribute. And the other big thing is really changing the way we think about assessment and using entrustment, and focusing on integrity, reliability, and humility, and not just ability, right? So when we need to trust our physicians, there's so much more that comes into place than just their ability. We want to be forward-facing rather than backward-facing to really tap into the power of EPAs. And we want to, and the beauty of all this is the emphasis on consequences, right? There are consequences for the patient. And when we say that someone is entrustable and send someone out there, is that it's not just rating the student, it's not just grading the student. This this has very real consequences for our patients and for our society. And so I think that as we think about changing our curriculum using an EPA framework, is I really want us to be thinking about all of these things, that it really is a paradigm shift in how we think about curriculum. It's not just a new curriculum on paper. And that's it. Thank you.
A continuación, la doctora Liz Hamui dará los comentarios sobre la conferencia magistral.
Do you have your... No, ok. Pues muchísimas gracias a la doctora Chen por esta excelente plática que vuelve a tocar el tema de las actividades profesionales confiables o EPAs, Entrustable Professional Activities, como se conocen a nivel internacional en este caso. Y ella hace un ejercicio de cómo aplicar estas EPAs en diseños curriculares o en mapas curriculares que de alguna manera atraviesen la formación de los médicos en el pregrado. Y en este sentido resulta valioso porque muchas veces las EPAs han sido diseñadas principalmente para estudios de posgrado y las residencias médicas. Sin embargo, estas pueden ser realmente útiles en la educación médica de pregrado, ¿no? Entonces, bueno, es interesante ver que para planear un currículum de pregrado con las EPAs, tendríamos que pensar de manera inversa. En vez de empezar con primer año, empezar con el último año y los perfiles de egreso y entender cómo estos perfiles de egreso finalmente van lográndose en los diferentes grados de arriba hacia abajo, más bien. Y en ese sentido resulta interesante la propuesta que nos hace la doctora Chen. Casi siempre las EPAs se asocian con la práctica clínica. Y eso resulta interesante. En la plática que tuvimos oportunidad de tener ayer, el doctor Tenkate y la doctora Chen, vimos que también puede ser factible bajar las EPAs o llevar las EPAs a las ciencias básicas igualmente en esquemas modulares de educación. Así que, bueno, creo que es un área que tenemos que trabajar y sería interesante poderlo trabajar de manera conjunta para ver qué tanto podemos empezar a incorporar a los estudiantes desde los primeros 2 años de la carrera a experiencias clínicas de alguna manera. En fin, lo cierto es que las EPAs tienen el potencial de articular el mapa curricular tanto a nivel vertical como a nivel horizontal y tanto en el tiempo desde el punto de vista, como nos explicaba la doctora Chen, en retrospectiva, pero también en prospectiva. Es decir, los tiempos y los espacios finalmente se mueven y se articulan en esta estructura curricular que nosotros podríamos diseñar teniendo como sustento las actividades profesionales confiables en ese sentido. No es una situación fácil, realmente se trata de un proceso complejo que implica diferentes capas o niveles, tanto digamos en lo más micro, en el salón de clases y en las interacciones entre profesores y estudiantes, a nivel meso, en programas institucionales que sean viables y a nivel macro, en una educación que prepare a los estudiantes para que tengan las competencias suficientes y se puedan desempeñar profesionalmente en su relación con los pacientes. Así que en este sentido pensamos que se trata de un proceso complejo, pero que vale la pena ensayar, porque la medicina no es simple. La medicina sin duda es una actividad compleja para la cual tenemos que preparar a nuestros estudiantes. Y bueno, hemos pensado también, y lo hemos compartido con la doctora Chen, con el doctor Tenkate, Tencate, que sin duda pensar en planes de estudio, nuevos planes de estudio modulares podría ser una buena idea para flexibilizar el currículum y poder en un momento dado lograr la aplicación de las EPAs en estos diseños curriculares que sin duda están ahí. Y bueno, muchas veces cuando se habla de las competencias se piensa en logros de resultados concretos, en eficiencia y en otros temas, pero realmente las EPAs incluyen una gran cantidad de valores profesionales, de ética, que efectivamente están incorporados. Es decir, no solamente se trata de conocimientos y de habilidades, sino gracias al ejercicio de las EPAs, podemos también detectar actitudes, valores, podemos promover que nuestros estudiantes sean más autónomos, responsables, que aprendan a comunicarse mejor, incluso como menciona la doctora Chen, que sean humildes, ¿no? Y que sepan reconocer hasta dónde pueden llegar y qué pueden hacer y qué deben derivar en otro momento. O sea, eso es una cuestión importante, que aprendan a trabajar en equipo, que sean profesionales en lo que hacen, que apoyen a otros a su alrededor, que actúen con integridad y, por supuesto, que logren la confianza de los otros. Tanto la confianza, digamos, por su conocimiento científico y por la aplicación de los protocolos biomédicos que en un momento dado puedan implementar, como la confianza moral que en un momento dado puedan tener con sus pacientes. Y en este sentido, cuando hablamos de confiabilidad, nos referimos a eso, la confiabilidad de que esto finalmente pueda desempeñar un médico. Pero aquí me parece que una de las grandes aportaciones de las EPAs, y que habría que mencionar, tiene que ver también con el tema de la supervisión que la doctora Chen ha desarrollado de manera amplia en su presentación. A veces hablamos de didáctica, pero en este caso, cuando nos referimos a las EPAs o a las actividades profesionales confiables, sin duda el tema clave tiene que ver con la supervisión. Y es esa supervisión la que coloca en el centro la relación entre el profesor y el estudiante. Y por eso resulta tan importante definirla, establecer diferentes tipos de supervisión y ver cómo esto finalmente se va dando hasta que poco a poco, a medida que el estudiante va siendo competente, la supervisión se va retirando hasta que finalmente él es capaz de desarrollar la competencia con confianza, ¿no? Con confianza y con competencia finalmente, ¿no? Entonces, me parece que el tema de la supervisión es muy importante y se liga, por supuesto, con el tema de la evaluación, que también ha sido explicado por la doctora Chen. Solamente comentar que en torno a la didáctica, el estudio de casos es importante cuando hablamos de las actividades profesionales confiables, ¿no? Desde el punto de vista multidisciplinar y que sin duda las materias y los contenidos se aprenden a través de los casos y de la aplicación en la práctica clínica cotidiana. Entonces, en ese sentido es importante. Finalmente, me gustaría referirme al tema de la evaluación y sin duda la evaluación no es un aspecto desligado del proceso educativo. La evaluación está articulada a la planeación, a la práctica, está articulada también a la supervisión del profesor y podemos decir entonces que hay dos tipos de evaluación, la formativa y la sumativa, y por supuesto las actividades profesionales confiables están estrechamente ligadas y vinculadas a la evaluación formativa del día a día del desempeño de los propios estudiantes, lo que no elude que en un momento dado se puede incorporar también a la evaluación sumativa para que haya congruencia entre lo que el estudiante aprende y lo que se le evalúa al estudiante en ese sentido. Y esto nos permite diversificar las fuentes de la evaluación, es decir, ya no solamente son los exámenes de opción múltiple, sino también podremos tener a la observación, tener rúbricas, por ejemplo, y por ejemplo utilizar diferentes tipos de escalas, como las que nos mostró la doctora Chen en su plática, para la evaluación. Por supuesto, los ECOES, o el examen objetivo estructurado, sin duda también es un recurso interesante que se puede utilizar también para la evaluación de las habilidades, los conocimientos y las actitudes de los estudiantes. Pues solamente terminar comentando que sin duda el objetivo último de la educación médica está en esa posibilidad de atender al otro, en esa posibilidad de ayudar a nuestros pacientes y de hacer que nuestras sociedades sean más saludables. Así que muchísimas gracias a la doctora Chen por su excelente plática y eso sería. Gracias.
Bueno.